Welcome back. We're here in San Diego at the Myeloma 2018 meeting. We've just finished our second day of sessions, another very exciting morning. I'm joined today by Dr. Tom Martin, my friend from the University of California, San Francisco, and by Professor Florian Bassermann from Munich in Germany. And I'm just going to start by asking both of you, what got you excited this morning? What did you see in our sessions that were focused on drug resistance and CAR-T immunotherapy that you were enthused about?
So this morning we saw quite a bit actually on drug resistance, and what Flori showed what I thought was really interesting, that it's not just cereblon, the target for lenalidomide, but there's other targets including CD147, MCT1, and also the CD98 LAT1 story. I thought that was a really interesting story. And then the second half was more on the immunotherapy. I think we're all excited about the immunotherapy. We had 4 or 5 presentations on CAR T cells. Our initial CAR T trials have all looked at BCMA as a target, but we're now going out to look at other markers. And I think an interesting one is SLAMF7. And in fact, we had a nice presentation from MD Anderson where they're trying to do a universal CAR T against SLAMF7, meaning it's from a donor and it's on the shelf, and you can take it off the shelf and give it to a patient when they have relapsed disease and target a different antigen other than BCMA. I thought that was really interesting. That's preliminary. And here, just like at some of our other meetings, the BCMA targeted therapy with CAR-Ts is really amazing. In these truly refractory patients, 7 or 8 prior lines of therapy, they're getting progression-free survival durations of 12 months, of a year, and that's off therapy for a year. So I think that's really exciting. I think in the next 2 to 3 years, we're really going to find out how well these CAR-Ts are going to work in the relapse refractory setting and also at earlier lines of therapy.
We also heard about BiTE therapy, which I was quite impressed with. What do you think, Florian?
I think the BiTE data was amazing.
What did they show, just for the audience who weren't there?
Well, they showed that we have, though a BiTE is an antibody, it's an off-the-shelf drug, where you have a drug that recruits T cells to the myeloma cell. And again, here the target is BCMA. And Dr. Einzeler from Würzburg presented data on their trial on the BCMA BiTE antibody. And that data in multiple refractory disease was really impressive, probably pretty close to what we see with CAR T cells in the moment. So it will be interesting to see what will be the superior therapy in the end. One thing is for sure, from the logistics, the off-the-shelf BiTE will be more easily available or readily available than the CAR T cell approach.
So the sense I had taking that whole session, which was very exciting, was that we're still learning a lot about CAR-T, and there's a lot we don't know. The technology's changing, the management of side effects are changing. There's a little bit of a reality check. Initially, everybody thought everybody was getting cured. Then we see 50% are relapsing within a year. So I sort of had a balanced optimism there that it's going to be great, but maybe not quite as great as we thought it was initially. Is that your sense, or are you still?
I think that's a great term for that, balanced optimism. Yes, I think that's actually great. I do think that in these really refractory patients, their T cells probably are not as healthy. And so when we rev them up in the test tube and give them back, they probably don't work as well as they're going to work when we use it in people maybe that are in the first relapse, or even patients that are newly diagnosed in their first remission. I think getting those T cells and then making CARs out of them actually may have more profound effects. Right now with induction therapy and transplant, we probably cure about 10% of patients. Not many, but maybe with CAR-Ts we can change that to 20, 30, or 40%. That would be really amazing.
Mm-hmm. What about the drug resistance session this morning? The other thing there, I was sitting listening to it, wondering, how are we actually going to apply this in practice? I think that people had developed ways of defining who was likely to respond to a drug or not respond, but there wasn't really an instance where you said, well, you shouldn't take the drug. So it sort of felt to me like it was all very scientifically interesting, but maybe not going to change. Apart from your talk, of course, which was a little bit different, but those algorithms to predict response, do you think we'll ever use those clinically?
I think, though, my major take-home message from that session was You cannot look at genomics and proteomics individually. If we want to find real markers for response, we have to go like for a panomic approach, so understand genomics, but also proteomics, even metabolomics, and then really get the markers, but also identify the vulnerabilities for new therapies. I think that goes along. Understanding resistance mechanisms and identifying new targets. For me, that was the major take-home message. Combine your approaches and then analyze them in a combined manner.
The science of that's getting very sophisticated. I mean, I'm thinking back to Dr. Trudell's presentation yesterday, where you were looking at single cells to see if they responded to a treatment or not amongst the billions of cells that we have with myeloma. So once again, I think a very exciting day at Myeloma 2018. It's amazing every year how we come together, and the science has evolved so quickly and so impressively, and we talk about cure every year with a little bit more optimism and enthusiasm. So thank you both for joining me, and thank you for participating in some of our videos from the meeting this year.